Hi everyone, I'm Valentina and this is just a little bit of teaching material or a bit of a refresher for anyone that wants to give it a go at my ReCoDe project on survival analysis of left truncated and right sensor data using the UK Biobank as an example. So just a little bit of a layout of what this presentation will include. I will do a brief recap into introduction of survival analysis, mainly focused on the type of censorings that there are, including right censoring, interval censoring, and left censoring, as well as how it differs from truncation. As well, I will go through univariable survival analysis, so this is without adjusting for anything, and then multivariable survival analysis that we use when we want to adjust for different covariates in sort of like more complex analysis. I'll then give you a few examples on survival analysis that is conducted in population cohorts, and then the differences of using time on study versus age as a time scale, as well as what the implications are for using these two types of time scales and how the results may be impacted or different. And as well, just a brief conclusion on perhaps what is the best approach when using these large cohort data and when handling survival analysis with lots and lots of data. But firstly, what is survival analysis and what are the aims of it? So survival analysis is a statistical method used to estimate the probability of a person or a group of people surviving over time, meaning not experiencing the event of interest. In this case, I'm referring to death, for example, so that's why we call it surviving. However, the event may be a disease or a specific type of death. There's quite a bit of flexibility on what the event may be. And what we say is the probability of these people surviving beyond a certain period of time, and that's what we will refer to as a survival function. From the survival analysis, we're able to compare these survival probabilities between different groups, but most useful, we're able to estimate the risk of developing the event, whether it's death or disease, after and compare it between the two groups or however many groups we have. And most importantly, if used in large epidemiological studies, we can adjust for covariates. What I mean by covariates is any sort of variable or factor that may be impacting our results and our associations. And just for you to start putting it a little bit into perspective of what do I mean by this here's just an example of different types of survival analysis. So the data is usually collected from cohort studies or randomized clinical trials. That's the more common way, but you may use it you may apply it on any other scenario if you got data that you want to look at from a start to an endpoint with a specific event. However, just here, I just got a few examples just to show you that. So we may have time to death. That would be an example of a survival analysis. Time to progression of cancer, time to developing chronic obstructive pulmonary disease or diabetes. I just giving you, it may be any other disease. I'm just giving you these two examples because that's sort of like my area of expertise of respiratory diseases and any other like comorbidities or cardiovascular diseases. That's just my examples, but it may be anything else. Time to event data, as I said, is typically collected from cohort studies. So this is what we use to do the time between study baseline, so whenever the study started, and the event of interest. Clinical trials, it may be the time between the randomization, whenever all of our patients were recruited, and the event of interest. And this may be referred to as the time of event or time until failure. Okay, so whenever we conduct this survival analysis, the outcome of it is the time until the event occurs. For example, the best scenario would be from birth. So that would mean that you follow everyone from whenever they were born to the time, for example, when they die. But there are actually very few studies that have followed up a lot of people and each participant from birth. So instead, the alternative is to use different starting times, such as the time of recruitment, so whenever they, for example, join the study. And the outcome of a survival analysis can also be until time of censoring, meaning that the participant does not complete survival time as the event of interest was not observed. But I will go a bit more in detail on what I mean by censoring and the different type of censorings as I move along this presentation, so just hang on with me. Okay, so let me introduce to you what censoring is. So individuals are said to be censored if they do not have the exact survival times. So what do I mean by this? So for example, if they have been lost to follow-up, or if they have died during the study, only if we're not investigating mortality. For example, if we are looking at disease, then we may use death as a censoring point. However, if we are looking at mortality, so if our outcome is looking at certain type of death or death, then we cannot say that dying would be censoring as that's our outcome. However, there's also fixed censoring. For example, if the end of the study has been reached and no event has occurred. So for example, in the UK Biobank, we determined, or we set for the end of the study or censoring date to be January 2023, and that was the time in which there was a last update on the mortality data. So what we mean essentially is like, if we censor our participants, what we are saying is that the exact survival time of these individuals is unknown. Okay, and there are three different types of censorings that I will get through on the next few slides. So first of all, it's right censoring, interval censoring, and left censoring. And we assume that censoring is non-informative. For example, if an individual is censored, the subsequent risk of the event of interest is totally unaffected. So I will go through each different type of censoring in the next few slides, but firstly, the most common type of censoring is right censoring, and this is when it occurs when a subject or a participant leaves the study before the event occurs, okay, or if the study ends before the event has occurred, as well as I mentioned before, if the patient has died, only if we're not looking at mortality. So let's go through this graph in a little bit more detail. So for example, this person over here, we would censor that person and we would say is right censored because they entered the study and they survived. So for example, let's say we are looking at mortality and this person has survived all the way to the end of our study. So we would say they didn't experience the event, so that person is censored. We also have another scenario here. In this case, the person was lost to follow-up or withdraw. So this person said, I don't want to continue in the study, and we set that person to be censored. And then just an example here, we have another participant that experienced the event. So that means, for example, in this case, let's say that we're looking at different type of mortality. So this person, we say, okay, throughout our start time and end time, that person has died. So we would say they experienced the event. We also have interval censoring, which is common, especially for outcomes that have to be assessed at different study visits. So what do I mean by this? So let's say, for example, we're looking at patients that need to be seen at different times, different follow-up times. And let's say we are looking for a viral infection, so that is our event and our outcome. So let's say we have a person that comes in at time 0, so let's say that's recruitment, then a person comes in at time 1 again, time 1, time 2, and then time 3, and that's our end of study. So as you can see, we have different time points that the person has to come into the clinic, for example, and we need to test them for a viral load. So for example, just to check whether they have the virus or not. And then we realize that at visit number 2, for example, this person has a positive test, but we say that this person has interval censoring because we cannot tell at what point specifically between time 1 and time 2, for example, that person was infected with the virus. So that's what we mean by interval censoring. We also have left censoring, and this is a bit more like a special or like a rare scenario. And this is when people enroll in the study have already have the event of interest. And it is very uncommon for participants to have the event of interest before the study has started, because they're usually excluded. However, there may be certain scenarios where, for example, let's say this is our start of the study and this is the end of our study, and let's, for example, say that we are looking at chickenpox. So we would say that the person at some point between their lifetimes had chickenpox, and that's our event. So we would left censor them because we know that they had chickenpox before they entered the study and before our study started. And as I said, this is a bit of like a rare scenario, so it's not commonly seen, as often these people would just simply be excluded from our study. So I have mentioned about left truncation before, and you're probably starting to wonder, how is this different from left censoring? So truncation is deliberate and is due to the study design. So what it essentially means is that the way that the study was designed to be conducted, in one way or another biases the results. So left truncation occurs when the subjects have been at risk before entering the study. And unlike left censoring, the event of interest is not necessarily observed. So truncation really is due to sampling biases that only those individuals whose lifetime lie within a certain interval can be observed. So if I start linking it to our UK Biobank example, the minimum truncation age is 40 years, which is the minimum age that the participants had to be to enter the study or to be recruited. Similarly, in the UK Biobank and in like many large cohort studies, participants are recruited over a large period of time. So for example, anything between 2006 and 2010. And this is often because we are collecting data and we're recruiting a lot of participants, so it makes it harder for it to be collected at one single time point. So what this really means is that participants recruited over the many years, they have a delayed entry that we need to account for in our analysis. Similarly, the time from birth to recruitment is missing, which means that the survivorship biases. So for example, in the UK Biobank, you had to be alive at 40 years old to actually enter the study. Anything between 40 to 69 years old, because that was the ages that the participants were recruited. So all of these things need to be accounted for and are often missed in large cohort data when conducting survival analysis. So it's very important that a minute is taken for you to understand your data and for you to really conduct your analysis as accurate as possible by accounting for all of these possible scenarios. And really, after you've taken the time to really understand your data and the type of truncation and censoring that may be present in your type of data, then you can move on into conducting and starting to conduct your survival analysis. So there's really two big types of survival analysis that I'll be talking to you today about, and it's either a adjusted survival analysis or unadjusted. So unadjusted is what we say to be a very simple model, and that's what I'll start with. So Kaplan-Meier curves are commonly used to estimate survival functions in unadjusted survival analysis. So it's very easy to use, and you can easily estimate survivor functions, and this is really the probability of not experiencing an event of interest. For example, if we're looking at death, what's the probability of surviving beyond a certain period of time? And then what we can do is that we can compare the differences between our two groups. So for example, using a log rank test to test the statistically significant differences between the two groups at any point during the follow-up, where we say, as frequently used, a p-value less than 0.05 would be significant. However, this is not very informative and it's not very useful when we use large epidemiological studies where there could be potential confounders and covariates that need to be considered that may be affecting our results. So this is where an adjusted survival analysis comes in. So we usually, for this multivariate analysis, we use a Cox proportional hazard model. And what it basically uses is a regression models that we can use to obtain the hazard ratio. We can be used to estimate the risk of developing the event of interest over our period of time. So in large epidemiological studies, it is important to adjust for potential confounders when we carry out survival analysis. And the hazard ratio, as I said, we can get from this Cox proportional hazard model. And as I said, we can use this to estimate the risk of developing our event. So before we move on to the next part of the presentation, I just want us to take a moment to go through an example, a very simple example, for you to start understanding everything that I've sort of been talking about for the past 15 minutes. So let's say we conduct a very simple survival analysis. So we run a Cox proportional hazard model on our two groups here. So group 1 in orange and group 2 in purple. So apart from us already seeing graphically the two differences between group 1 in orange here and group 2 in purple, our hazard ratio that was calculated was 2.3. So what does this actually mean? So all it means is that the risk of dying, because we're looking at death as our outcome, in group 2 is 2.3 times higher than individuals who are in group 1. And we can see by the rapid decline that we can see on the purple line compared to the orange line, which also is declining but not as rapid as purple line, for example. And then from these you can go on and calculate a log rank test in which will simply indicate whether the differences between the two groups are statistically different. However, just as a sort of like a guide for you to really see this, you can see that the two lines aren't really crossing, so you can already start suspecting that the differences between the two groups in survival will be statistically different. But in practice, when you have large and complex model where you're adjusting for many covariates, it's very difficult to see this in a graphical way, because you will have curves for every single covariate that you go, which will make it very hard to see it graphically, which is why we don't recommend to use Kaplan-Meier curves unless you're conducting a simple unadjusted model. So we start sort of shifting our focus a little bit towards our ReCoDe example using the UK Biobank. In this case, we wanted to investigate the mortality risk in participants with airflow obstruction, which we define using different spirometry measures. But these may have been, could have been defined in other ways with doctor diagnosis or different measures if you wanted to. However, in our case, this is the definition that we had. We determined the data to be right sensor up to January 2023, and this is when we had the latest UK Biobank mortality data update, and we also set the data to be left truncated. And this was because the minimum recruitment age was 40 years, and participants had a different start time, so they could enter the study at any point between 2006 and 2010. So that means that the subject entered the analysis at the baseline age, which is what we call left truncation. So really, what is the most appropriate approach to take into account the left truncation and the right censoring? So as I said at the beginning, the different timescales that may be used in a survival analysis. But traditionally, time on study is used, and what we do is simply adjust for age as a covariate in our Cox regression model. So using time on study as the timescale, all subjects enter the risk set for the model altogether at time 0, which in this case would be time at recruitment. However, this isn't often the best approach when using large cohort data such as the UK Biobank, where participants enter the study at different times. So just for simplicity, I'm going to use a very simple example here on the right hand side. So if we look at this line represents a participant. So if we looked at 4 years, everyone is sort of, if we were to draw, let's do this just for simple. If we were to draw a line here at 4 years, we can see that everyone sort of falls on that line or below that line. So what we say is that 4 years of follow-up, all the participants are at risk of experiencing the event. However, if we then look at a different time point, let's say for example 6 years here, only 4 subjects are in the risk set, as one of them was eliminated due to the event. The event here in this one here, and another one was eliminated because of censoring. So in this case, it could have been due to loss of follow-up or withdrawal from the study. So really, with the time scale, what the model does is that it computes the risk based on all the subjects whose follow-up durations were greater than whatever the given time is. So whether it's 4 years or 6 years or whatever the time point is. Therefore, the increase in risk of the outcome is the same for each year, regardless of age. So no accounting really from the impact of age may have, although the underlying risk may actually change with age. So this is a problem, and this is why we need to take a moment to think about what is the best timescale to use when using large cohort data. Okay, so let's briefly have a look at how much our results or how much our model would change if we were to use age instead of time on study as the timescale in our survival analysis. So using the age as the timescale, subjects enter the risk set at the age when they enter the study and exit at their event or the censoring age. So when age is the timescale, time 0 would actually be birth. However, like in the UK Biobank, like most cohort data, this is not the case. So what we do is we have them enter the risk set at the age when they enter the study, given that they have lived to this age with no occurrence of the event, which in our case is death, meaning that they're still alive. We can therefore account for left truncation and delayed entry using this method. Left truncations allow us to put the subjects in risk set only when they're actually under follow-up by the study, which is necessary when age is the timescale. So again, just like in previous method 1, let's run through a simple example just for you to start understanding it a little bit better. So my example here on the right hand side, using age as the timescale. So at the event at age 57, so this is the one here, 57, what the model is doing is computing the risk estimates for those who were 50 years old, whether they were 57 at baseline or not. And this is particularly useful for some cases, as we would expect the hazard ratio anyways to change more as a function of age than as a function of time on study. So for example, we would expect more of a difference in particular disease risks, for example, between someone who is 30 and someone who is 60 years old, for someone who has been in a study with the same amount of follow-up, than between 2 participants with the same age but different amounts of follow-up. So really, it is recommended to use age as the timescale, which puts subjects with similar risk in risk sets together. So in our case, it is more appropriate to use age as the timescale to accurately analyze the UK Biobank dataset. So what are the implications of using the 2 approaches, for example, in a UK Biobank dataset? So I'm just going to present you some Cox regression results that I've completely made up. They don't have to necessarily match the ones that we will do later in the ReCoDe project, but just for you to understand and have an idea. So in here, the results are using both approaches when estimated mortality risk in participants with airflow obstruction. And I've adjusted the models for different confounders, in this case age, sex, smoking status, smoking pack years, Townsend deprivation index, UK Biobank center, and ethnicity. And the traditional approach using time on study as the timescale, so only accounting for right censoring, resulting in a hazard ratio of 1.41. So that means that the mortality risk in people with airflow obstruction is 1.41 times higher than in those without airflow obstruction. I then moved on to conduct the same analysis However, in this time, using age as this timescale, meaning that I didn't adjust for age because that's already accounted for in the timescale, but then I have a hazard ratio of 1.32, meaning that the risk of people with airflow obstruction, the mortality risk of people with airflow obstructions is 1.32 times higher compared to those without airflow obstruction. So in this second model, we are accounting for left truncation with a minimum age of 40 years old. So that's when minimum age to for people to enter the study. And as you can see from these two results, in this case, the results did not change massively, but it is important to consider which approach is most suitable for your specific type of data. To accurately identify the presence of censor and truncating data, I recommend that you follow the steps that I've been sort of guiding you through in this presentation. But importantly, it's necessary to present your results as accurate as possible without accounting for all of this, which could bias your results. And yeah, as I said, in this case, the difference in the hazard ratio is not massive, but it may be that in another type of analysis, the results may differ drastically. So it's important to report the accurate results. So having said that, really the strength of using age of the timescale in large population cohorts, such as the UK Biobank, where the population age is high, so for 40 to 69 years old, and the recruitment was done over several years, it means that it directly takes into account the effect of age on mortality. So as I said, there's no need for it to adjust it in the model. You can also account for left truncation if it is present, which is often in large cohort data. And the observed survival probability is based on the participant's age instead of on how many years the participant has been on the study. And finally, the effect of the risk factor is as a function of age and not as a function of time on study. And then just for you to sort of have at the back of your mind that although this is a more complex analysis, there's even more complex one where survival analysis will require spline-based approaches to estimate time-varying coefficients and test for proportionality, but that is beyond the scope of the ReCoDe project and what I'm gonna talk to you today about. And finally, some of the conclusions from this survival analysis that we conducted is that the results from the Cox regressions are better than those from the Kaplan-Meier curves because specifically in epidemiological studies, so we can adjust for covariates. And I will give you a bit more examples of tables and way that we can illustrate the results of multivariable survival analysis in the ReCoDe project as we move along. And using the age as a timescale has multiple advantages, especially when working with older population cohorts in which we can account for the risk of age in our model. And it is important to select the proper timescale when conducting survival analysis in population cohorts. And it is very important that you take a moment to really understand your data and organize your data correctly to estimate the mortality risk or the risk of whatever event you're looking at as accurate as possible. Thank you very much for sort of listening to this sort of introductory, whether it was an introductory tutorial or just a bit of a refresher, and I hope you find the ReCoDe project as useful as possible and that it can give you some insights into how to have better practices for conducting survival analysis in large cohort data.